not only that, though, there was the component, the nice component of the anesthesia process was that we kept a very close view of what was actually happening in the operating room. So this was married with a real-time schedule and sort of like a patient tracking device. So it was possible, because we knew who was sitting at which workstation at any point in the anesthesia process, to actually track a patient through the entire process from the moment they arrived to the moment they left. So this had all sorts of possibilities. We could give to the patient waiting area a big screen and track who was in the patient waiting. The folks in the waiting area could tell relatives, you know, what's happening in real time to their loved ones, and anesthesiologists could walk around with PDAs and stuff and actually see what was going on in real time to their patients through the system. And there was a nice linkage. You could click on any one of these patients and pull up their records. It was a nice mix of tracking and business and recording, which made a very good mix. And the relevance of all of this is that it was made very, very possible by by an open source project. Now, originally, the code was written by me in JSPs. I became a Java programmer and started the project off. But even though I knew most of what was going on, I quickly became bewildered. All of those people, all these stories around when you write a big project like this, the pressure was on, had to work. There was a mixture of, I remember there was a terrible mixture of business logic and views actually in the code itself. It became bewildering, which was the cause and the reason why people would adopt an open source program like Struts. The idea behind Struts was it was supposed to put order in your code, separate out your model from your business logic, from your views. And I became a very early adopter of the Struts community in 2000, 2001, realizing I had a problem and this was a solution to do that. And what was so marvelous was that here was a community who actively wanted to help me finish this project. So it was a very, very early stage of the Struts program. I could write to the creator of Struts, who at the time was something of a guru called Craig R. McClanahan. He was God in the open source community. He had donated the code for Struts, and he would write me and help me and send me little code fragments. And that was really a rather marvelous situation to be in. So this program was actually built with the help of an open source community and was taken on from that. And it allowed the code to actually be put in a format that I could give it to a team of people and they could see what was going on and then develop it further. So that was the second thing that was very important to this. I stopped being the sole developer of this and gave it to a team who could then take it on to things that was absolutely not possible for me to do on my own. So that was the benefit of this. It was transferred, and because it was involved in this open source community and put in such a way, I was able to actually attract developers and given the responsibility to do this to actually make it much better than it otherwise would have been. So the architecture and the open source roots of this enabled me to get a team of developers together who would never otherwise have been interested in a project like this. So they certainly wouldn't have done it for the money that Duke was prepared to pay, and the challenge became a very creative challenge for these particular chaps. And they took it on to a completely new level. Our view became a completely integrated perioperative management suite, from all of the billing processes to the preoperative assessment. We actually wrote a very nice little electronic medical record associated with this, pre-op questionnaire, the whole OR management suite, an anesthesia record, the nursing record. We put everything we could to it in an incredibly, an explosion of creativity within this particular group. You know, it looked good. I mean, we had, you can see elements there of the preoperative record, the anesthesia record. Everything was expressed on a PDA, the very earliest PDAs. If you came to Duke and you had an anesthetic, somebody would pop round and see you with an early Microsoft PDA and take down, you know, were you feeling sick afterwards? We had lookups and everything. It was a complete solution for the perioperative experience. It was a portal. We were able to put all the reporting aspects of it. You know, it was used by the business leaders to see what was happening in periop across the system. It was a tracking system. We had big screens at a time when these were very, very rare in hospitals, and we actually put a big screen solution up like this where you could see the entire vision of what was going on in the operating rooms across a few screens that just cost a few $1,000s. Alternatives at other centers that tried to do this, they'd hire in a CA Associates or an IBM, and it would cost hundreds of thousands of dollars for them to put in screens like this and paint them, and we could do it for a few thousand of commodity systems with a nice video card. So it was a very good system at this time. It was also actually one of the earliest examples of a RIO. Duke had 3 hospitals, and we put this web wrapper on top of all the individual systems that they had. So they had a different scheduling system at Durham Regional Hospital, different anesthesia system, and this system converged by putting this wrapper on top of it, all of the individual systems that were adopted. So you could have a single view with a single currency of what an anesthesia record looked like and a single schedule, even though the underlying systems themselves were completely different. So, and what that also did, it had a number of interesting effects. It meant that when we swapped out one particular vendor, the end users never actually saw the change because they were actually using this for their patient care, and not the point of care system was just commoditized to a recording system. So that was one of the very interesting effects of this particular technology. So the relevance of that, it was at the time a magical combination. We had complete access to all the clinical data, and I heard somebody say yesterday that one of the limiting factors of development was the fact that you didn't have access to this type of data. Well, we did, because we were in control of it. We had maximum domain expertise, very closely aligned to the development effort, and the organization at the time was very grateful for it. And the system was well used. It's coming up to its 10th birthday now at Duke, I'm told. It works extremely well. It still continues to run the entire perioperative process. They haven't replaced it with anything better at the time. So it's a well-used system. It won the Computer World Honors Award Program for Medicine in 2006 against some pretty stiff competition. So, but it's not all a great. I mean, although it's still used, we reached a stage where we tried to commercialize it, and it was dependent on a number of very stodgy companies, Draeger and Siemens. Were some of the underlying systems. And I said, I actually gave the software to Duke at a very early stage because I had a significant conflict of interest. I was in a position to, although I was the inventor of the software, I then started up a team that was developing it. So of course I was in the cycle of conflict. And I gave the software to Duke in return for an increased cut if ever they should make money out of it. And then when we tried to commercialize it, I tried to get the software back. And that was very, very difficult indeed. Duke had no interest in pushing it out, and the companies that underlay it, like Draeger, had no interest at all in trying to commercialize it because it actually didn't help their particular systems. So it broke my heart trying to commercialize this. And there was another opportunity that arose, which was in South Carolina. So, and I'll tell you about now, because that's the second story associated with these systems. I told you the second one was of a slightly different flavor, and it involves this entity called Health Sciences South Carolina, which is a collaborative of the HSSC is a collaborative of the major universities and major hospitals in the state. So I was asked to come to South Carolina and start up information systems where hospitals would share data, put it into a reference clinical database, and they thought, at the time they talked about interoperable medical records across the state because of the sharing of data. That was the original concept associated with that. And they had some vague ideas around this putting a research portal on top of that. And of course I had the same idea that I was going to take from Duke, that we would use these web-based architectures to put it all together, and that was what I understood. So my concept was to take the Duke model and use it in what we were going to do in South Carolina, and that was a very naive way to go into what we were talking about here. The actual system, the work itself was funded by the Duke Endowment. There was about $7.5 million was going to be set aside for this effort. There was state matching funds associated to an endowed chairs program. South Carolina was quite imaginative in how it put the personnel and the underlying funding for this sort of project together. And the end goal, as it began to crystallize, was to create a research-centric infrastructure that would leapfrog South Carolina into the forefront of medical research at a national scale. So it was a greenfield opportunity with some money, and the concept was that there would be data warehouses and statewide tools to facilitate research, tissue repositories, and genomics databases. That was the overarching concept behind the opportunity in South Carolina. But there really was nothing here at all beforehand. The two biomedical informatics faculty that existed in the state down at the Medical University of South Carolina had left because there was no prospect and no funding for them to do anything. So HSSC started off, and the first thing we had to do was to basically set a mission statement for what we were going to do in IT. It was around the concept of collaborative health sciences research to improve health status, education and workforce for all South Carolinians, basically by attracting significant funding to South Carolina for HSS, for health sciences research, attracting scientists to South Carolina so that they can bring IP, and then creating an attractive health-related, creating and attracting companies to South Carolina who would want to increase these jobs. I'm not sure why that slide is in there. It's a little bit over the top. But from our IT viewpoint, certainly we wanted to establish an information technology program that supported translational research. There was a need to do so at the statewide scale because MUSC had aspirations to get a clinical and translational science award. And there was no IT infrastructure, certainly no informatics infrastructure in the state that they could to support such an environment. So there was a dual role, not only come in and get these systems going, but also provide the smarts necessary for MUSC to show its credentials for a CTSA award. And at the same time, we were going to build this informatics group. So essentially, the goal was to build an analytics engine at the statewide scale in South Carolina. The concepts of a data warehouse, a clinical trials management system, an EIRB system, something that would enable the state to function in an integrated way for translational research. And some infrastructural pieces had already been put in place. A very high-speed internet network was put in between the hospitals and the universities. We were supposed to use that. And I'll tell you more about what that engine consisted of. But one of the most significant and imaginative components of this was the concept of a statewide, a real-time clinical data warehouse in the state. Now, going back, South Carolina has had two unique properties that made these types of collaborative issues, collaborative projects very possible. One is the geography of the state. You'll see that the hospitals that are chosen here are pretty much separated by 100 miles, except for Spartanburg and Greenville. It meant that there's very little competition, local competition between them. They were just far enough apart for them not to be internecine with each other. And of course, I think everyone in the state realized that they had a tremendous need for a system like this. The concept of leapfrogging and pushing South Carolina forward was very much in state legislators and healthcare leadership's mind in the state.